Mr. Chairman, dear colleague, I would like to thank the GECO and Jean-Yves Lasnec who organized this very nice meeting to invite me for that. Please, the slides. Okay, yeah. Well, on the panel, who has the experience of anterior revision surgery for disc replacement? 1, 2, 3, 4, 5, 6, 7, 10. Okay, quite around 10. Well, anterior exposure has become an increasingly popular procedure due to the increased use of anterior devices and disc replacement and fusion. Everybody knows the high satisfaction rate of patient, but there is a very limited insight into the incidence of failure. Revision operations have become increasingly necessary. Despite this, there's almost no literature dealing with the issues related to this complex revision operation. And we need a strategy. And I would like this kind of strategy we have. The first is a patient selection. And you see it's completely different if you have this the patient on the right or the patient on the left. There is different situation, the patient complaint and the surgeon complaint. For the patient complaint, the pain could be related to the implant loosening, the malposition, or displacement. The pain could be related to the prosthesis implantation, and the pain, sometimes the pain is of unknown etiology, and more or less, sometimes adverse events like infection or access made the complication. But sometimes there is surgeon complaint due to the bad positioning and implant loosening or displacement involving high risk for the patient. Then the first step of the strategy is to identify the failure. It could be easy, like in this case with the loosening of the prosthesis, and the pain is related to the implant loosening. There is a radiograph, the radiographs show a technical reason, and here the polyp was non-snap. It could be difficult in case of patient with unknown etiology. And there is no evidence of technical problem. Then in the second step of the strategy, we have to determine what is bearable and what is unbearable. There are technical reasons for that. Bearable is a malposition, subsidence, loosening without any risk of neurovascular compromise, like in this case. The patient has, we'll see later, but the VAS and the ODI was not so bad for this patient. Some reasons are unbearable, like the loosening with displacement of the prosthesis and risk of neurovascular compromise. Sometimes the reasons are clinical. Bearable, the pain following disc implantation in patient with narrow disc or previous disc surgery. We can observe root pain post-op, and we have to wait a delay of 6 months before revision, research of compression with the sacroradicography. We have to assess the disc, the foramen, the prosthesis. Sometimes facet block or foraminal block could be interesting. In case of low back pain persistent, the cash test and conservative treatment could be efficient, and also the facet block. The unbearable reason is the pain related to implant malposition. For us, the indication of anterior revision is when there are high risks for the patient and in case of neurovascular compromise, and then we can change the prosthesis or replace the prosthesis, and in case of anterior approach with miscentering. This is for us the only indication of anterior revision. Then, once we have decided to make anterior revision, we need some preoperative considerations. Through review of the index procedure in the first step, and Professor Steib said you that we have to look at the patient of the previous surgery, the previous access. As a patient about the history of deep vein thrombosis, retrograde ejaculation, and infection, detailed physiotherapy examen is very important. In the preoperative considerations, regardless of the initial incision, retroperitoneum and ureters will likely have significant scarring. The left ureteral catheter must be placed bilaterally for L5S1 revision. Cell saver and both femoral areas are prepared for the potential need of surgical or endovascular repairs and or hemorrhage control using a transfemoral approach with balloon catheter and or stents. Pulse oximetry is obtained routinely from either the first or second toes of the left foot. Placement of an inferior vena cava filter before the procedure should also be a routine part of revision anterior procedure. The complete replacement of IDR requires significant side-to-side access to the spine. Replacement of the device is much more feasible in 5.1 than 4.5 or 4.3. Revision of the anterior lumbar surgery can be divided into two categories, the same level or adjacent level revisions. In the same level revision, it can be two situations can occur. It can be early from the 1 to 10 days and delayed over 10 days. We can perform an extended access to control the vessels above and below, and we can prevent vein bleeding compression with compression possibilities with wire loops. In case of revision, an access vascular surgeon could be available and very helpful for the surgeon with less experience. In case of same level revision in early situation or delays, returning early to any level is relatively easy through the original incision because there has been no time for fibrous adhesions to form and encapsulate the tissues. Even at 10 to 14 days, there is already a capsule thick enough to require incision with a scalpel surrounding a prior arthroplasty, like in this case. In the delayed cases, return through the original approach is practically impossible no matter how long after the index procedure, so alternative approaches are necessary. For 5.1, we recommend using the opposite side retroperitoneal route for the revision. The transperitoneal route will be a second alternative, but it requires bowel mobilization with possible bowel injury, increased incidence of retrograde ejaculation, and increased incidence of ileus. You see here in this drawing, the access must be done on the right side of the levels to avoid any kind of injury of the hypoglossal plexus. But even in this case, in the case of revision, it's always difficult to avoid any the lesion of the hypoglossal plexus. In 5.1, the ability to stay between the vessels offers some advantages and makes it somewhat less challenging than the level above. There is usually enough space to the right of the previously mobilized left common iliac vessels to provide good visualization of most of the disc space. The vessels are bluntly dissected toward the left as much as possible without using any sharp dissection that could inadvertently injure the hard to recognize fibrotic walls. This usually provides adequate working room for the spine surgeon. Retrograde ejaculation, however, is very difficult to prevent because the superior hypoglossal plexus can no longer be identified. For 4.5 and above, it is better to stay lateral to the previous dissection and use an anterolateral retroperitoneal approach. This has been described by Salvatore Brau in Los Angeles. This approach splits the abdominal muscles to find the peritoneum, which is then followed to and elevated from the psoas muscle. The psoas muscle is then followed to the anterolateral surface of the spine. Do not incise the psoas, but instead separate it from the lateral surface of the spine to obtain adequate access to the disc space. The upper approach should be started slightly above or below to where the prior approach will have elevated the peritoneum to find virgin territory between the psoas and the peritoneal sac. This can usually be done, thus reducing the incidence of peritoneal tears that can make exposure more difficult. Transperitoneal could be necessary in some cases. Here you have a right-sided approach. It could be done in the first case, but it could be difficult in revision surgery. We do not recommend it in case of revision surgery. And the most important complication then we can have with the right access approach in 4-5 is some cardiac arrest due to less blood into the right heart. Dealing with the vena cava and the prominent lumbar veins, this revision situation is to be avoided if possible. In 4-5 and above, the ureter is usually anterior to this plane. However, we have seen cases where the ureter was dragged down by the fibrous tissue and the catheter was identified very close to the areas of dissection. Even though ureteral catheters do not necessarily prevent ureteral injuries, it is always reassuring to be able to palpate the catheter and know that the ureter is away from the planes when using sharp dissection and cautery. Vascular injury in the form of major vein laceration and iliac artery thrombosis and laceration represent the major risk in attempting revision in anterior lumbar surgery with area surrounding 4-5. And it is a greatest challenge. The arterial injury. TDR requires complete exposure of the disc space for adequate AP placement of the device, and thus requires retraction of the aorta and left iliac artery at this level, far to the right. Since the iliac artery is encased in fibrous tissue and is fixed by scar to the anterior surface of the spine, it is no longer as elastic or movable. Then retraction of the vessel to the right causes significant stretch of the artery, leading to intimal disruption, and in some cases complete disruption of the right iliac artery wall. Intimal disruption leads to thrombosis and embolism. Venous injury. Venous injuries can be reduced through the experience of the access surgeon. Previously mobilized iliac veins are very difficult to identify because they are encased in thick fibrous tissue and are pulseless. It is best to use sharp dissection staying on bone once the vertebral body is identified. Elevating the fibrous tissue away from bone itself will help because this capsule is usually 2 to 4 millimeters thick and somewhat protects the vein wall. We use systematically CT angioscan, but in case of extrusion of mobilization of the device, it's very mandatory to have a venogram, because there is, in case of thrombus, it can be seen on the venogram, and then we can use a vena cava filter to avoid any kind of embolism before the revision. If the revision includes both the prior level and adjacent level, the adjacent level exposure should be carried out first. This allows identification of the vessels above or below, making it easier to mobilize them as they approach the area of fibrous encasement. The use of a barrier between the vessels and anterior surface of the spine has been recommended by Brow. It was helpful in dealing with revision and has been shown in one case to make dissection easier. I used once, and I have one revision with this kind of barrier, and it was very easy to lift up the barrier, and the tissue just underneath the barrier was more easily to discover, and we find more easily the prosthesis. But I had just one case of revision with this barrier. They have very small experience with that. Then removal of the artificial disc components provides yet another challenge in revision surgery. The surgeon has to know exactly what device is using. Different artificial discs have different bone implant interface and various degrees of modularity and constraint, and we spoke about it all the day long. In general, the more modular the implant, the easier the extraction. For unconstrained prosthesis, removal of the polyethylene core proceeds first, followed by removal of the superior and inferior end plate. Osteotomes, curettes, and rongers are required to remove encasing bone and dislodge the prosthesis from the vertebral end plate. Like in this case, we use the osteotome just to detach the vertebral end plate from the bone. Keel prosthesis requires specialized removal instruments or partial vertebrectomy. Degree of destruction of the vertebral end plate will dictate the choice of anterior colon reconstruction and the potential need for posterior fixation. The postoperative management. After exposure, hardware revision and closure, a nasogastric tube could be left in place to reduce abdominal distension and ileus. Hourly bilateral neurovascular examination with dorsalis pedis and posterior tibial pulse check is typically accomplished. The ureteral stents and Foley catheter are typically removed on the second postoperative day. In conclusion, revision surgery for lumbar antibody arthrodesis and total disc replacement represents a challenge for the surgeon from both a diagnostic and a technical perspective. Careful patient selection based on objective signs and structural problems found on radiographic evaluation helps guide the decision for non-operative versus operative care. Neurological and radiographic evaluation will dictate the most appropriate surgical approach. Revision anterior surgery poses life-threatening risk. However, proactive perioperative planning and careful exposure tend to minimize these problems. Finally, I'd like a take-home message. We have to keep in mind that perioperative patient conference to discuss increased risk. Review prior records to determine prior device and approach. Evaluate prior and current imaging studies. Perform additional imaging studies, venogram, CT angio, MRI, in selected case only. Use cell saver in all cases. Prep groins and have endovascular devices available. Use pulse oximeter on left great or second toe. Use barrier between vessels and anterior surface of the spine in primary cases. Avoid long paramedian incision with extensive mobilization of the retroperitoneum in primary cases. Use the right retroperitoneal approach for pulsing level in 5-1 procedure and even 4-5 and above. Thank you for your attention.